Hello and welcome to this Inside Digital Health and Collective Medical webinar. My name is Samara Rosenfeld and I'm the Assistant Editor of Inside Digital Health. I will be the moderator of today's hour-long webinar titled Reducing Emergency Department Visits and Addressing Social Determinants of Care Through Collaborative Outreach, Peer Support, and Case Management, featuring Becky Wilkinson, Regional Behavioral Health Outreach Program Manager at Providence Health and Services. Today, Wilkinson will be discussing how Providence uses its Better Outcomes Through Bridges programs to help its most vulnerable behavioral health patients. This topic of addressing social determinants of care is so necessary today as health systems are transitioning from fee-for-service models to value-based care. It is now on the provider to meet patients where they are and help them with their overall health and well-being, not just when they're in the four walls of a healthcare facility. Throughout this program, please feel free to use the question tab to submit questions. Becky will answer them as she sees appropriate and will also leave time at the end of the webinar to hit on anything else. Now, I would like to introduce Becky. Becky, take it away.
Thank you so much. So thank you guys for joining this afternoon. So I'm going to talk about our Better Outcomes Through Bridges programs as mentioned. These are fairly new programs that are focused on working with some of our most vulnerable patients. We have started this program a couple of years ago. We started originally out of the ER, and we now have programs based out of primary care, school outreach, and some other programs that I'm going to talk about. Hang on a second. Sorry about this. There we go. So Bob, as I mentioned, focuses on serving some of our most vulnerable patients. We are really working on serving our most poor and vulnerable, focusing on some patients that have the highest ED utilization, the highest number of social determinants of health, and truly have the most needs. So as I mentioned, these are some of the programs that we are working on. We have ED outreach, we have a housing project, a clinic outreach program, school-based outreach, and now peer support. A lot of people ask me what is an outreach specialist. An outreach specialist is not a clinician. So I am a social worker, but our team consists of bachelor's level outreach workers who are somewhat between a peer and a clinician. That's the best way I can describe them. So most of the team has their own lived experience, which is not required to be an outreach specialist. It is required to have lived experience if you are on our peer support team, and that's a program that I'll talk about a little later. When we hire people for this program, it's very intentional hiring. And when I say that, I mean that we screen people very thoroughly to make sure that people understand trauma-informed care, make sure that people are really aware of their own biases and privilege, because we are working with such a vulnerable population that has been really systemically traumatized all over the place. And so it's really important to me that people are doing this work for the right reason. And so again, we are very intentional in our hiring process. So this slide talks a little bit about some of our interventions, philosophies, and innovative practice. As I mentioned, just a couple minutes ago, this work is really focusing on working with our most vulnerable patients. And so pretty much everything we're doing is innovative. As I mentioned, we started off doing ED outreach out of one of our hospital emergency departments, and I'll talk a little bit about that program later. And along with that, we run specific multidisciplinary team meetings, basically bringing together each discipline of the ER in a room, talking about really vulnerable cases. And as we're going to talk about a little bit later, how we integrate that with Eddie care plans. We really focus on innovative solutions. This is work that hasn't been done out of this hospital system before. We spend most of our time in the community working with people, and therefore we get a really different view of people's lives than just the snapshot that's often seen while they're in the hospital. So when I say meeting patients where they're at, I mean, as corny as it sounds, literally and figuratively, we meet people where they're at. So we let people guide their care. So we're going to walk alongside someone. We are not going to say, you need to go to treatment, you need to do this. We're really going to meet them where they're at and let them guide their care and let them create their own goals. You know, the idea behind that is really truly being trauma informed. As I mentioned, people come to us really as kind of, you know, the last stop. They've been in and out of the hospital systems, in and out of the ER. Maybe they've been kicked out of clinics. Maybe, you know, they're just kind of on their last step. And so we often get people, you know, when they're in a really vulnerable state. And so they really don't need somebody else telling them, yeah, you need to go to treatment and you need to do this before we can work together. Redefining success, that is a big one. I often, you'll see, I'm going to share some data slides later in the webinar. And when I talk about redefining success, it means, okay, so maybe this person was coming into the ED, you know, they had 100 ED visits within the last 12 months. Maybe they're still coming in, not quite as much, but hey, they meet me every time that I ask them to. You know, they're following up with their doctor's appointments. They're doing everything that they've agreed with me that they will do. And so that to me is really looking at things in the most successful way. So what does success look like for each different person rather than just putting people in a box? And becoming a change agent, as I mentioned, you know, a lot of this is new work. These are new programs. I started with Providence about 2 years ago. When I came on, we had just one ER outreach worker out of one of our metro hospitals. And as you can see, we have grown significantly. And cultivating relationships, this is a huge one. This is pretty much the core of the work we do. I get a lot of questions around how we get such good outcomes. What do I think, you know, is driving that? And to be honest, I really, truly think it is just relationship building. Not only relationship building with our clients, but relationship building with the hospital staff, in the ER, inpatient, and really our community partners. We could not do this work without our community partners. There is just absolutely no way. So I'm going to start off talking about a clinic outreach program that started a little over a year ago. Here is just kind of an overview of where we're at. We are in a rural health, what is considered a rural health clinic. We have an outreach team based out of internal medicine, family medicine, and our behavioral health clinic. And so the internal medicine and family medicine teams focus on social determinants of health. So every patient that comes into the clinic who has Medicare and Medicaid are screened for social determinants of health, and you can see the criteria there. It's through a grant through CMS, the Center for Medicare and Medicaid Services. It's called the Accountable Health Communities Grant. So the criteria for that is in the blue middle box. We also have out of this clinic, they share time in the clinic and in the ER, as well as working with the behavioral health team. And so I'll go into a little bit more about the Accountable Health Communities navigation and grant. So these are slides that were put together by myself and people from the grant managers who are helping to run the Accountable Health Communities navigation. So they screen, as I mentioned, all patients that have Medicare and Medicaid. Approximately 10% of those people who are screened are eligible for navigation. And this data was pulled we started this in May, and this data is for about 5 months, from May until the end of October. So far, 101 patients have been eligible for navigation and 83 have accepted. So the navigation can last up to a year. And I'm going to show you on this next screen. These were the top needs that were navigated. So they ask a series of questions to patients that are all focused around needs in transportation, housing, food, utilities, and safety. And so this is kind of the pie chart of what those top needs were. And here's just a little bit more information on those needs. So 61 needs have been identified that have been addressed by our team. 9 are still being worked on. These cases can be open for up to a year. And so we, again, utilize the same kind of overarching letting the patient guide our care with that Accountable Health Communities grant. So I wanted to share our behavioral health clinic in Newburgh. Our outreach worker who is in that clinic shared this story with us, and I wanted to share it with you. It's just kind of an example of a demographic of people that we're working with. Of course, the name and any identifying information has been changed, but Kevin was a referral to our outreach specialist to assist in helping with permanent housing. He had a history of substance use. He had chronic pain and a felony on his record, which are all barriers to get stable housing. He had a Section 8 voucher, but he only had 2 weeks left until it expired. So our team recognized immediately that that was a huge need, that we needed to help him get that extended, because we know that those are few and far between to come by. So we assisted Kevin in getting an extension on that voucher, and that was granted, thank goodness. So the outreach specialist mentioned to me when we were talking about this case how impressed she was with Kevin's kind of determination to overcome all of these barriers that he was constantly facing. So he was on the road to recovery. He was working part-time and volunteering at a local nonprofit. He really felt strongly about wanting to give back to his community that he felt helped him so much. So through their search together, they were really fortunate to find a property manager who was willing to look past his record and to see all the positive changes that he made. So one of the big barriers was not having enough money for a security deposit. So he did have a little bit of money saved, and with the help of our team, we were able to work with a community partner to help pay the rest of his security deposit. And so he was able to get his apartment, move in, and he is now working full-time at the nonprofit that he was volunteering for. And this is just one of the cases that I am always happy to talk about, because I feel like, you know, for somebody that is living on the street and has this many barriers, and, you know, they're dealing with, you know, already feeling down and out and battling their own behavioral health issues as well as medical issues, and really trying to just kind of get back on their feet, having somebody right next to them help them along the way is just invaluable. And that's not something that, you know, is typically available within the hospital or clinic system. And you know, we are really fortunate to be able to work with Kevin and see his progress. And not only that, just showing this amazing example of working with multiple agencies across systems to help this one person. And that has made a huge difference. So in Newburgh community, we also have a school outreach program. So in partnership with the Community Wellness Collective, which is a local nonprofit in the area, and a local family foundation, this project has been funded through the school year of 2021. And how this started was a couple of years ago, the community saw an influx of completed suicides, and unfortunately at that time didn't have a way to address really helping those students. And So with the help of Providence, the Community Wellness Collective, and this Family Foundation, they really work together to bring in a suicide screener into the school district, to fund and bring in school outreach workers who really work off of the same model as the other programs in, meeting people where they're at, helping to address social determinants of health needs and behavioral health needs, and spending time with people in the community, really showing up and being in the school day to day, being a staple there, being somebody that kids can count on and families can count on, because it's not just working with kids, it's working with the entire family. And so right now we have outreach workers that are based, working with 6 schools within this school district. To date, we started this almost a year ago, and we have had 80 students up to date. And what I found interesting is they have, when we track social determinants of health for the students that we're seeing, we also track social support needs. And that is by far the highest need that everyone across the board has said, that they are lacking a stable social support. So it just kind of goes to show how important meeting somebody where they're at is. So now I'm going to talk about our emergency department outreach program. So this is our criteria for the ED outreach program. Patients need to have a minimum of 6 ER visits within 6 weeks, or 20 in 12 months, along with a behavioral health condition. And we do look at utilization rates at that particular hospital. Right now we have outreach workers at 5 of our Oregon hospitals. And as I mentioned, we have the ER-specific multidisciplinary team meetings. We really use that same model of walking alongside the patient, and to be honest, we really rely on the EDI system in our work a lot. So when we look at utilizing the collective medical platform, I can honestly say this is the single most useful tool that we have available to us. So we track our cohorts, we track ED utilization, we are able to look at managing our caseload through there, we track referrals, we gather a lot of data and information, and of course we manage care plans. We run reports regularly through here. Again, this is like the single most important tool that we have. And when we look at creating care plans, we have, as I mentioned, each of the ERs that we work out of, we have these multidisciplinary team meetings. And so we get together monthly and we look at cases that, that maybe need a little more help, need a little more. We don't necessarily do care plans on every patient that we work with. But our team has gotten together, including physicians, nurses, social workers, psychiatry, social work, and of course our outreach team, and have decided that in order for a care plan to be effective, that we are going to focus on only making it have 3 main bullet points. So we focus on what is this patient's typical baseline. So I know if they are showing up into the ER and they're presenting in some way that is different than their baseline, something is extremely wrong. We also focus on what is the specific intervention that will be most helpful for this patient's care while they're in the ER. And that can be, we've had cases where maybe it's triggering for security to be on standby. However, we know that the person may have a history of violence towards staff. So we've worked with security to put a jacket on over so that they're still there to protect our caregivers and our patient, but they're not necessarily triggering our patient. And the most important thing is who can we contact for a safe discharge plan? So that would be the last bullet point. And do they, are they working with the outreach worker? Does the outreach worker want to be contacted every time they come into the ED. We do get notified via EDI through our email every time a patient in our EDI cohort comes into an ER. We're not always next to our computers, so do we want to put our phone number in there and be called every time they come in? Or do they have a family member or friend that maybe is going to be soothing for the patient during their time in the ER? Is that somebody that that wants to be called and be there, or somebody that wants to help with the discharge plan? So we are really trying to be very mindful and intentional when we create these care plans. We do create them with patients if it's appropriate. We want to make sure that we're transparent and we are getting buy-in on the patient's care. So a little bit about Collective Medical. It's a platform that allows, as I mentioned, tracking. For us, we utilize it for tracking caseloads, for gathering data, for running reports, for creating care plans. And so Collective is a network of hospitals, EDs, primary care specialists, behavioral health clinics, and it's an information sharing platform. So this talks a little bit about the workflow and what it looks like when a patient presents into the hospital, and how we are alerted that through the EDI system that they are in our hospital. We also utilize EDI to put in safety alerts. As I mentioned, sometimes patients have a history of violence towards our staff, and so we want to really ensure that everyone knows of that, so that they can act in a safe way when they are treating our patients. And so here is a little more information. This is on the right-hand side is what the EDI care plan and alert system looks like. And these are the standard guidelines on the left-hand side. So patients that have a minimum of 5 ER visits within 12 months automatically get triggered for an EDI notification. And then you can see for traveling patients, if they've gone to 3 different EDs within 90 days. And then obviously if they have a safety and security event. So the PDMP is a prescription drug monitoring program, and that is also, if you can see on the example on the right-hand side, it's about midway down, and it lists any medications that any controlled drugs that the patient may have been prescribed, the amount, the date, and by whom. And so we utilize that information really to help guide care. Is this a flag? Is this not? Is this something that we need to, put into our, into the care plan? Do we want to address this? How can we best help this patient? I'm going to go into a little bit more about the ED MDT meetings. As I mentioned, we agreed on this standard format for our MDTs. And I have to say, this has been really informational for me. As I mentioned, these programs are pretty new. We started the MDTs, I guess about a little over a year ago, and we currently do them at 3 of our sites, and plan to actually we do them at 4 of our sites and plan to expand to the 5th one soon. This has been, the feedback that I've gotten around these MDT meetings has been really phenomenally positive. As I mentioned, we get ED docs, psychiatrists. We also bring in community partners as appropriate, and really try to get buy-in from all of the people that are working with our patients. And I think the most positive feedback that I've received on this has been from our doctors, who really didn't fully understand the depth of the work that was happening in the community with the patients that they were seeing over and over again. And so that's been pretty impactful for them. I feel like They have told me time and time again, our psychiatrists and our ED doctors, how valuable it is to hear all of the different programs that are helping our patients, because they see the snapshot of somebody when they come in, and then they discharge them, and then they see them again, and then they discharge, and so they're often don't get the full picture of what's going on. And so this has been really helpful for them to see that there is a lot of work being done in the community, and I think it's really just made a positive impact all the way around. And our community partners, I have heard from our community partners that attend these meetings how valuable it is for them to see our actual ED docs. As we all know, their time is so limited, and our psychiatrists are limited as well. And to see them taking the time out of their busy day to show up and to bring their medical and psychiatric expertise to the table to really help care for our vulnerable patients has been huge. So now to talk about some of our data. So this is our second quarter year-to-date BOB program outcomes. This number represents 128 of our clients, and this was for all active ED BOB clients from July of 2018 to June of 2019. We showed a 42% of our clients showed a 50% reduction in ED utilization. And so I'm going to share this slide. And so this kind of breaks it down by hospital system. It just shows the graph in a little bit of a different way by site. You can see the blue bar is baseline ED utilization per member per month. And the orange bar is post-ED utilization, basically post-BOB intervention. And some of the numbers you can see are a little low because those programs are fairly new. So I'm really excited to see what these numbers are going to look like as our programs grow. And this is just a funny slide that our data analysts made up, just a different way of looking at the same information. Sometimes the graphics kind of show things a little differently. So we're going to talk a little bit about housing. So as I mentioned in the beginning, we started off the BOB program as just one person in one of our ERs doing ER outreach. And when I came on about 2 years ago, it was with the intention that we were going to look at growing this program. And I have to be honest, I am so thrilled and never could have imagined that this would be as big as this is now. So as we started expanding into different ERs and we started looking at the different needs of our really vulnerable patients, we had this unique opportunity because we could see things in a different way because we were in the community with people. And as I mentioned, the ED, it's just one snapshot. So we were really able to spend more time with our patients, meeting them where they're at, and really working with them to address all these social determinants of health. So this slide was pulled, this data is pulled from August of 18 through August of 19, and this represents a total of 167 patients. This was our total active BOB clients. So 38% of those during that chunk of time were identified as homeless or facing imminent homelessness. And 25% of those we were able to connect to stable housing. So that also represents 63 people. And so that's where we started looking at what can we do to help our patients get into housing. As we all know, all across the US is a housing crisis. And unfortunately, it's probably only going to get worse. About a little over a year ago, I knew that we were going to start expanding into one of our rural communities in Oregon, and that we were looking at starting a program out of their ER there. And so with my networking, I came across a group called the Metropolitan Alliance for Common Good. And so essentially what they are is a national organization that helps communities do community organizing. And they had a housing team specific to this community going on for about 2 years, they told me. And I was unaware at the time, but this particular community had the second highest homeless rate in the state of Oregon and still has 0 overnight shelters. And this group was looking at introducing this safe overnight shelter model into that community. And I'll explain more what that means in a little bit, but they lacked case management to attach to it, meaning, you know, if we were going to help people get housed or get housed into a transitional or emergency shelter situation, how would we help them along the way? How would we help them get to the next step? What is after that? And so luckily, right around that same time, I had gotten an email about a grant opportunity and asked them if they would be interested in partnering with us if we helped provide case management and started promoting this project. Would they want to work together? And they said yes. So this particular community at that time had 2,300 homeless people. Over half of that were kids. And as I mentioned, 0 overnight shelters. So what the model is introducing to churches, landowners, businesses to allow safe overnight car camping in their parking lots or these tiny micro homes, as you can see. And what our team would do would be provide case management to people living on site. And so the agreement is that when we find a church, for example, that maybe wants to host 3 cars in their parking lot overnight for people experiencing homelessness, we will case manage everyone living there in exchange for using one of the slots for people coming out of one of our ERs in the area. And so when we look at this program, we have just started this. We actually didn't realize how much groundwork this was going to take, talking to different city municipalities, counties, really doing so much networking with churches, landowners, business owners, to really educate on the state of homelessness, to look at how each of us can really help in that. For Providence Health, we share a very similar mission to a lot of churches in the area. And so it seemed like a natural fit and a great partnership. And so we are really spending a lot of time working with churches to see if this is the right fit for their congregation. And as I mentioned, how we can educate more on the state of homelessness and really, you know, utilizing this opportunity to recognize that we have to think outside the box in order to address these social determinants for our vulnerable patients. And this program, this housing project, is no exception. You know, we know, as I mentioned, all of us know that are listening, there is a housing crisis, and I don't really believe that there is one fix for this. And I think it's really just going to take creative solutions, tailoring to each specific community on what it looks like. And so maybe there are going to be some churches that have this safe overnight shelter model. Maybe some places are going to do tiny homes, you know, models that really allow flexibility and again, attaching support with that. I can't emphasize enough that I truly feel like relationship is the single most important thing that we can do to help our most vulnerable patients, is really spending that time to relationship build. And again, being in the community, building relationships with our community partners, because we cannot do this alone. We do not have all the resources available to us, and nor do we want to do it alone. So here is one of the partnerships that was created out of this project. So Agape Village is a tiny home village that is being built behind a church in our community. They have 15 tiny homes, and with our grant funding, we have funded 2 of those homes for patients that are exiting our ERs. And so in exchange for 8 hours a week of case management services and 8 hours a week of on-site peer support services to all the people living in the village, we will have sole access to 2 of the tiny homes. And the picture on the right is, they just actually finished the homes yesterday, so I don't have an updated picture, but the picture on the right is one of our homes. So they have ramps. They're not ADA compliant because they're just not big enough, but we did test it out, and somebody with a walker can go up that ramp. So they'll be fully furnished, and this is a pilot project. So we have agreed to let people stay in there for up to 45 days. We get a lot of referrals for patients that discharge and maybe just need to keep their cast dry. You know, that we are in Portland, it rains a lot of the time. It's hard to stay dry when you're living on the streets. Maybe somebody just needs respite for a few weeks. And so this is an opportunity for them to have that rest time, rest and recover. And so this is really exciting for us. We are, as I mentioned, the 2 tiny homes were completed yesterday, and we are hoping to move our first people in by mid-month, if all goes well. And so this is just another example of a creative solution to a large problem. We know 2 tiny homes are not going to solve anything. We know by working with churches and having 3 car camping slots is not going to solve anything. But as you'll hear when I continue to talk about this, just the opportunity to inspire others to do similar work and to show that this can be done, that's more than we can ask for. This is 2 more people or 2 more homes that's going to allow people to be off the streets and hopefully connect with our team and work towards longer term stability. So this housing story project was in conjunction with our housing teen group that I mentioned earlier, and this was something that we helped fund with our grant money to really educate people on the state of homelessness. And so this is what they call like a living art project, and this was set up at a couple of different events along with one of the, not the tiny homes, but one of the huts that you saw in an earlier photo, and you'll get all the slides after this, to show the statistics. What is the face of homelessness? Who are the people that are lacking secure housing? You know, we could all be one step away from this. And so what are the statistics around this? And so this was a walkthrough display really featuring statistics about this specific community and what are showing the reasons why we have such a spike in homelessness. So this was really kind of a cool art project that was really impactful for a lot of people. We actually had some people that work for our hospital system that lived near the areas where these were set up and said it was really well done, and they felt like, as somebody that didn't really know about the state of homelessness, was really educational. So this talks a little bit more. I know this is a lot to read, so I'll just highlight a few things. This really talks about our grant. So when I talked about that grant that I applied for this housing project, we were allowed to, with that grant funding, we hired 1 outreach person, and of course we set aside funding to help with the tiny home village and other things to help get this project going. I'm really happy to say that we were granted a second 2-year grant through this specific county to continue this work. So we've been able to expand it, and we will be able to continue it for the next couple of years. And through this work and talking about this, as I mentioned, really having the opportunity to inspire others to do similar work, we were able to start a patient overnight parking program at one of our other hospitals. So we have space available for people that are working with our BOB program outreach workers that can sleep overnight in we're just starting a second one of our hospitals. So they are able to stay 7 p.m. to 7 a.m. They need to be actively working with our outreach team on longer term goals, and they will receive food vouchers for dinner and for breakfast. And this actually just purely started by accident in, again, talking about this work, coinciding with somebody on my team asking about one of their clients who needed a safe place to sleep in their car. And so I had asked permission, and up to this point, at one of the hospitals, we've been doing this for about 6 months. We have hosted 4 patients to date, sleeping in the parking lot, and with the help of our community partners, we've been able to house all 4 of them permanently. So again, it's not solving the crisis, but that's 4 people off the street for our patients. And I mean, these people are really vulnerable at the time. And so they had the opportunity to work with our team hand in hand, and for our team to use their community connections to help them along the way. And so we're hoping to start that at another hospital, and really looking at how can we expand this across other sites, and writing policies that would allow us to do that. We have been talking to multiple different agencies within the area of this grant about other partnerships, just again, trying to be creative. Can we work with the parts department on expanding their camping permit from 2 weeks to 4 weeks? Would they be willing to, help let us use some of their parks that maybe aren't being used right now because of lack of funding? Can we help? Just what did those different partnerships look like? And so this just is kind of a large summary of all of that. And so I want to talk a little bit about this client. He has worked with our outreach worker on this housing project, and when he came to us, he was living on the streets. He had multiple chronic medical issues. He is a veteran and had been living outside for about 5 years. He had about 6 ER visits and 3 inpatient hospitalizations within the 6 weeks prior to a referral to our team. So he was coming in the ER because he couldn't address his diabetes. He has chronic heart failure, and we suspect maybe mild dementia. And he has given a full release for us to share this information. So with our community partners, there were about 10 organizations, I think, working on this case. We were able to get him connected to housing, and of course, through all of our advocacy and continued work with him, once he's able to kind of get rested and recovering from just the trauma of living on the streets, he's been able to manage his medical care better. And now we've had a chance to work with him on longer term goals along with all the community partners. So he now has in-home health and things like that. So this is just another example of kind of who we're working with, and the creative things that we're doing with our community to help those that are really most vulnerable. And so I'm going to talk a little bit more, this is the last item, about the community work that we do. So these are just an example of some of the things that we are working on in the community with our community partners. So one of the requirements that I have for the team is that they are involved in their community, wherever that is. Each of the different sites, there are different resource meetings happening, there are different, whatever it is in that particular community, be a part of. So really learn the people, meet, who you need to, so that we can help our patients get services later down the road. And, as I mentioned, I just keep mentioning it's relationship, and I really, really believe that. I also run a large community outreach meeting. This was kind of a grassroots organic meeting that happened quite a few years ago, and I brought it with me to Providence. So we get together every month. I have people in the area that either have new or existing programs that talk about their programs, talk about ways we can work together for our vulnerable patients, and really just kind of learn about what people are doing in the community. We utilize that space as a great time to network and meet people face to face. I also run a large listserv and share resources. So when I get resources sent to me, as you know, now we're in winter, like for example, the winter shelters, I'll send those out to the community. And this is, as I mentioned, it's really just kind of an organically grown grassroots effort that that's happened over the years, but it's really well attended and people love it. So our peer support program, this is something that's only just about 6 months old. This started actually to address an Oregon state law that said all the hospitals in the state of Oregon have to follow up by law for people who had presented in a behavioral health crisis. And so the law said that the people can follow up telephonically. Either a behavioral health clinician can do the follow-up call to our patients or a peer support specialist. And I've worked in the community doing this work for over 10 years now, and I know the value of having peer support on our team. Somebody that has lived experience, that has lived on the street, that has battled substance use disorder, having that person be able to share their experience to help another person is one of the most valuable things other than relationship building. So we hired peer support specialists to do this work for us. And so we have 3 peer support specialists. And we call the program Caring Contacts. And so every day they work 7 days a week, you know, obviously staggered shifts. They provide follow-up calls to our patients who all across the state who have discharged that originally presented in a behavioral crisis. And so they also spend their time in the community. They are located in Portland, and after they have connected with all the people they need to via telephone, there are people that they work with in the community. If it's local and somebody needs a little extra helping hand, they will sit with them in detox if that's what needs to happen. They will meet them in their home. They'll take them to coffee. They will do whatever they need to help, again, connect to services, provide support. We had one of our peer supports help someone gain employment, and really, you know, all they did was just from knowing through their own experience was to really talk them through the process and, you know, just encourage them, support them, and give referrals to where they felt like would be good fits. And I know we're running out of time, so I'll wrap this up in just a minute. And so this is just another slide that talks a little bit more about the peer support program. We are currently following up with 7 out of our 8 hospitals in Oregon. We do the Caring Contacts follow-up calls. The other hospital has their own process to follow up. And again, we focus on meeting people where they're at and networking with our community partners. And the last story I'm going to share is this story. Again, we have permission to share this. In fact, I had asked our peer support to double check, even though he signed all the releases and the media releases, and I said, can you just double, triple check that he is okay with us sharing his story if we talk about this at meetings? And he said, she actually showed me the message, and he said, I would be honored for you to share my story. If it helps one person, if it inspires one person, I would be honored. So I'm going to read you guys this. So it says, Dear Bob team, I wanted to send a personal thank you for all the support you've given me through my transition into the housing program at Blackburn Center, and that's a local housing program. You guys were there for me when everyone else turned their back, and I want to give a special shout out to DJ, that is our peer support specialist who worked with him. She walked beside me every step of the way, and if it wasn't for her, I don't know where I'd be today. In the beginning of August, I was ready to end my life. I was living on the streets after getting kicked out of my sober house for relapsing on methamphetamines. I had nowhere to turn. I lost all hope. Someone suggested that I go to the emergency room at Providence in Portland instead of throwing in the towel. I left there with a list of resources and a city team voucher, which is a local shelter voucher. I felt so alone. The day after I discharged, I received a call from DJ Alex at Providence. She said she was a peer support outreach specialist and that she was calling to see how I was doing. Calling to see how I'm doing? My first thought was, why would she care how I was doing? She kept me on the phone for 45 minutes that morning and set up a time to meet with me that very afternoon. For the first time in months, I found some hope. I didn't want to die. I was ready to live. You see, I've been trying to get sober since 2012 after using for over 20 years. I've graduated numerous treatment centers and had solid transitions plans, but within 6 to 9 months, I would relapse. I refused mental health services, took only some of the suggestions in the recovery community, and before long, I would find myself back in the life I've been trying to get away from. The Bob program helped me save my life. Today, my children have their father, and I have more community support than I ever have. I am living my best life today. Again, thank you so much for not giving up on me. Sincerely grateful, Mark Meeks. And he is still in the housing program. And I know we are close to ending time. And this is just a quick slide to where do we go from here. I'm excited to see what 2020 will bring for us. I mean, if we can, inspire change and continue to cultivate new and existing relationships and more opportunities for growth and expansion, so be it. And this is our team. Thanks, you guys, so much. So I'm sorry I ran a little over, and now we can open it up for questions.
All right, so we actually did get several questions along with a shout out to DJ. So the first question, with community navigation, will you guys be using Thrive Local Unite Us?
So that's a Kaiser program, and I have to be honest, I am not completely educated on what all that entails. However, they are coming to the outreach meeting, I believe, at our January meeting to talk. So I'm going to learn more. I did meet with the Unitas team and their director, and they are so awesome, and I know they're going to do amazing work, but that was quite a while ago, and I do not know about all the nuances with that program, so I cannot say.
All right, and a couple of people are asking about the name of the grant that you were talking about earlier on in the presentation.
Yeah, so the grant for the housing grant, that actually was through Providence. It was an innovation grant within our own system that I applied for, and actually had to do an entire Shark Tank style pitch to a huge group of people, and it was several months after I started, so it was a little nerve-wracking, but we got the grant, obviously. And the second grant is through Clackamas County Affordable Housing Fund. And that is the grant that's going to allow us to, that has allowed us to expand and continue this for the next couple of years.
Mm-hmm. All right, next question. Many traditional practitioners hold that serious mentally ill people will not accept these services and require outpatient commitment to force them to participate. What is your experience?
So, well, first off, working with our team is completely voluntary. So we will never force anybody to work with us. If there are cases of people that really have severe persistent mental illness and maybe don't necessarily have the skills or capacity to create goals with our team or to work one-on-one with us, that would be the perfect place to bring the case to a multidisciplinary team meeting. And we have had many cases like that come to our MDT meetings. And that's where we get together as a community and with our providers and talk about best practices. What can we do to help this person? Maybe they don't meet criteria for mental health hold or anything beyond that. So how can we wrap around and support this person as a community to really help make sure that they're safe and get what they need?
Mm-hmm. All right, we have 3 more questions. How does the housing project work for chronic homelessness?
So the housing project, so there's a couple different things going on with the housing project. So we have the patient overnight parking program, which is for patients that are working with our Bob team. And that is something that is very carefully and mindfully vetted. So patients go through a process of, with our team, and they have to agree to, behaviors and they have a whole sheet of agreements that they need to sign up for if they're going to stay on property. Along with that is working towards goals. So it's really meant for people that are wanting to get off of the streets into permanent housing. The Agape Village project is that we have the criteria to participate in that is 2 ED visits within the last 3 months or 2 inpatient visits within the last 3 months, along with a behavioral health condition. That village is self-governed, and all of the residents of that village are required to volunteer. And so that is going to be no different for our folks that are staying in the Bob, I'm calling them Bob bungalows. So they are going to have to volunteer. If they're not physically able to do hard labor, then they can do something that's light labor. But we're not excluding people that have chronic homelessness. It is, can they live in a community environment? Can they participate in the program? Can they work towards longer term goals? Can they volunteer? The safe overnight parking, again, it's the same thing. It's the slots are going to be open up to the community. So if a church, they're going to work on their own criteria of who's there. And then we just use one of the slots for people exiting out of our hospital system. So we're not excluding someone that has chronic homelessness. And again, we're not expecting to solve anything, but really just inspire people to do similar things and be really creative.
Now, another participant is curious about who would do the hazmat cleaning if a patient is a substance abuser and overdoses. Would it be the responsibility of the owners of the property or another agency?
So the churches that we're working with to introduce the safe overnight shelter, it is their program, really. So we are there to advise and to help in any other way. So if that is something that they will look at, hazmat cleaning. However, I can say that most of the churches we've talked to, that is part of the agreement that people are not to use illegal substances on the property. So if that were to come up, then it's most likely that the person would be expelled from the program. So, and the same deal with our patient overnight parking program and Agape Village. They're not to use illegal substances on property.
All right, Becky, and we just have one final question before we wrap up here. Someone would like to know if you put in any insight when your Bob team is working with members.
Meaning insight, well, so I do regular supervisions with my team, and we talk about cases all the time. So if people have questions, I'm always available if that's what they mean.
All right. Well, thank you so much, Becky. We are going to wrap it up here. Obviously, addressing social determinants is becoming increasingly important in healthcare today. Through implementation of platforms like collective medicals and programs like Better Outcomes through Bridges, health systems can more confidently tackle population health issues. We just wanted to remind everyone that the slides will be available on idigitalhealth.com along with this webinar recording. We would like to thank everyone for joining us and participating. And Becky, we really appreciate you being able to educate us on some of these very important issues. So thank you.
Thank you.